So a very warm welcome to this second instance of the modeling speaker series, where we speak about mathematical modeling and the connection to public health. And for those who are a bit less familiar with the talk series, it started with the ECDC COVID-19 Forecast Hub and the COVID-19 modeling community, also the Scenario Hub. And since the start of the COVID-19 hubs, this community also expanded beyond COVID-19 and beyond technical modeling aspects. So we're very happy to see these developments, of course. And the ambition of these talks, of the speaker series, is to cover topics that are relevant to public health modeling and also to widen our thinking beyond modeling. And I'm very happy today to announce our speaker, Joseph Wu, who will tell us about vaccine hesitancy monitoring and wastewater surveillance for epidemic nowcasting. And a few words on Joseph. He's a professor at Hong Kong University, and his research aims are to develop practical analytics and strategies for disease control and prevention, and to translate his research into policies and practice. And he's the director of Hong Kong University's first massive open online courseware, Epidemic. And he has worked on COVID-19, seasonal and pandemic influenza, and foot and mouth disease, HPV, MERS, yellow fever, cervical cancer, colorectal cancer, and breast cancer. Joseph has now 25 minutes to speak, and afterwards we have time for discussions and questions, and we aim to close the meeting at 10:20 Central European Time sharp. And over to Joseph.
Great. So I just try to share my PowerPoint. Are you able to see it?
Yes.
Great. So thank you for the kind introduction and the opportunity to speak to you on some of the work that my group has been doing during COVID and after COVID. So the title of my presentation today is Vaccine Hesitancy Monitoring and Wastewater Surveillance for Epidemic Nowcasting. So in this talk, I'm not going to focus on the techniques, but instead emphasize the importance of these two data streams, namely vaccine hesitancy and wastewater surveillance, which have not traditionally been considered in previous response to epidemics, for example, the 2009 swine flu pandemic. So COVID is really the first time that we were able to get, in some places, real-time or near real-time information on vaccine hesitancy and getting estimates of the presence or the prevalence of SARS-CoV-2 from sewage surveillance or wastewater surveillance. So first, just a few words on what we mean by epidemic nowcasting. So basically, it refers to assessing the current state of the epidemic by understanding practically all aspects of the ongoing outbreak, spanning from the pathological to epidemiological to clinical and social behavioral characteristics. And the objective is to provide situational awareness and informed decisions on control responses. So this figure shown here was from a paper by Mark Lipsitch and colleagues published before COVID, 2019, summarizing what we as modelers or data scientists do in the context of decision making. So what our job basically is try to assimilate the data from surveillance inputs, which is shown here at the bottom layer of the figure. So the data streams could be from confirmed case counts or virological surveillance or hospital-based data, etc. So we as modelers are trying to assimilate these data streams in order to generate evidence on different aspects of the epidemics to help inform decisions. So for example, at the very beginning of COVID-19 pandemic, decision makers were asking questions such as, what should be the overall scale of response? Namely, was the pandemic very, very transmissible? And if infected, what would be the chance of needing hospitalizations, which is a key question for estimating hospital beds demand. to see whether the hospital system will be overloaded or not. And in order to answer those questions, what we need are basic estimates of transmissibility, for example, the basic reproductive number, and also estimates of clinical severity, such as case fatality risk. So as I think many of you know, Mark helped set up the Center for Forecasting and Outbreak Analytics at the CDC in the past 2 years, basically catering to this need of epidemic nowcasting in the context of decision making. So before COVID, we already were very interested in working on so-called infodemics in the context of vaccine hesitancy. So as many of you know, infodemic, the digital advances could be a double-edged sword in the sense that it does provide a lot of information that were unprecedented, which could help us to understand the latest information about the epidemic and also public sentiments regarding both the epidemic itself and also the vaccines. But at the same time, it also allows things like conspiracies and scandals and misinformation and distrust to spread at unprecedented speed and scale. As with many cases about trust, once spread, misinformation is very difficult to eradicate, and once lost, trust and confidence is very difficult to regain. And this is particularly damaging in the context of pandemic vaccination, because that is the key for ending or substantially mitigating the health and economic damage of the pandemic. So this was not a new problem. It's not a problem specific to COVID-19. Professor Heidi Larson has been working on this since 2010, when she started the Vaccine Confidence Project at London School of Hygiene and Tropical Medicine. So in my lab, before COVID, we started working with Heidi's group. And in fact, the co-director of the VCP, Dr. Lisa Lin, is now a senior research director in my lab. So in collaboration, during COVID, we did a number of experiments to investigate, to explore the use of AI for mitigating vaccine hesitancy. So for example, in the paper at the lower right, we developed a chatbot. So this was before ChatGPT. So we developed a chatbot on COVID-19 vaccination in Thailand, Hong Kong, and Singapore, and did a trial study to investigate whether these chatbot interventions were effective in increasing vaccine acceptance. And what we found was that, that the result could be mixed, could be very different in different populations. So the results that we found could vary substantially between Hong Kong and Thailand. At the same time, within the same location, the effect could be very different across different demographics. For example, the impact of the bot on elderly versus adults could be very different. So it's not a one-size-fits-all solution, even if it's effective in some groups. The BMJ has a recent collection on talking about how are social media influencing vaccination. So for those in the audience who are interested in this area, I strongly suggest to take a look. So in this collection, there are a number of very well-written articles highlighting the gaps in our understanding of how social media influencing vaccination, and also the gaps in what is missing in not just the interventions that we have, but also ways that we try to come up with or test the effectiveness of these interventions. So for example, in this article at the top, the authors highlighted two major gaps. One is that they suggest one important step towards developing more effective interventions is the close monitoring of public perceptions and opinions about vaccination and services. And this is also what we found, as mentioned in the chatbot paper that I share with you, but also in our other studies showing that the public sentiments about vaccination could vary over time substantially, depending on what events unfold regarding the safety and effectiveness, or even the necessity of vaccination. Also, the authors emphasize that because most published interventions focused on attitudes and intentions rather than on actual vaccination, there remains an urgent need for direct partnership between behavioral researchers with healthcare clinics and public health agencies. So this is a very important point, because indeed, in most studies, it's very difficult to link the intervention administered to the subjects to what the subjects eventually do in terms of whether getting vaccinated or not. In most studies, the outcome would be vaccine confidence or vaccine acceptance based on surveys, but not actually on the outcome of whether these people get vaccinated or not. So there has been studies in the literature showing that what people say about their intention could be very different from what they actually do afterwards. And as you can imagine, linking clinical outcomes such as vaccination status in the long term or medium term is very difficult. So in Hong Kong, we had the opportunity to work with the Department of Health in order to access some of the vaccination records of our subjects. Unfortunately, I'm not able to share with you the results of that study yet, because that study still, the paper is still in preparation. So hopefully we'll be able to publish that study soon to disseminate the results. At the bottom are two papers that Lisa led. One is an opinion article on how Gen AI could have a role in combating vaccine hesitancy. So in this article, again, Lisa highlighted some of the potential use cases and also potential risk of deploying Gen AI on combating vaccine hesitancy. On the right is another project about chatbots in collaboration with colleagues from London School and Japan. So similar to the chatbot paper that we did in Thailand, Hong Kong, and Singapore, here we did a similar study in Japan. Okay, so deploying AI for monitoring vaccine confidence or help to improve vaccine confidence is, the framework is similar to what we do in typical epidemic control, which is first we need to have good surveillance, understand what the situation is, have accurate data on the ground truth, and then based on those information, design interventions, and then evaluate the effectiveness of those interventions and identify gaps and limitations in order to implement refinements, and then basically iterate. So in terms of framework, it's not new. What AI provides is that we can now do this at a much faster pace in terms of iterating through this loop, especially with the advent of LLMs, large language models, which allow us to massively scale tasks such as sentiment assessments or data curation, including generating or suggesting effective ways of framing different vaccine messages. So these things could be enhanced by LLMs, which facilitates this refinement cycle. So here's another study that Lisa is leading in China, which is to evaluate the effectiveness of, again, bots, but this time powered by ChatGPT-4, on the acceptance, knowledge, and behaviors related to HPV vaccination. And what she finds so far is that there are significant increases in HPV vaccine uptake, parental willingness to vaccinate daughters, knowledge of vaccines and information-seeking behaviors. This is another study that Lisa is leading, looking at the public sentiments about the use of mRNA vaccines. As many of you know, mRNA is a new technology that was deployed during COVID, and actually a substantial proportion of the public were skeptical, and I think are still skeptical about the reliability of the mRNA vaccines, especially on the long-term potential side effects of mRNA vaccines, because many of the general public, when they hear RNA or DNA, they immediately associated that with gene editing, which might impose some adverse effects on the host, on the vaccinee, not necessarily in the short term, but could manifest, in the medium or long term. So both the scientific community and also companies such as Moderna are very interested in keeping an eye, understanding what the publics are thinking and saying about not just mRNA COVID vaccines, but the mRNA technology in general. So here in this study, Lisa has been leading the work to build a dashboard to look at what people are saying or thinking about mRNA vaccines around the world. Okay, so for audience who are interested in learning more about our work in this area, please contact Lisa. Again, she's a senior research director in my lab and also an assistant professor at HTM. So next, I'm going to talk about wastewater surveillance. So before COVID, when people think about surveillance, we typically think about tracking cases, identifying cases, and then doing contact tracing in order to monitor potential new cases among the close contacts. And if cases are identified among the contacts, then they will be quarantined, and then further contact tracing will be done among the contacts of those contacts. So COVID is really the first time that wastewater surveillance were deployed at quite large scale in many places around the world. Again, this is not a new surveillance technology. Wastewater surveillance has been used for detecting, for example, polio circulation, but that's mostly for detecting the presence of pathogens that are not typically circulating substantially in the community. So basically, try to identify new cases as soon as possible. So here, in the context of COVID-19, wastewater surveillance have been used in different jurisdictions for different purposes. Case detection, when circulation is low, is definitely one of them. For example, in Hong Kong, during the first 2 years of COVID, we have been implementing the so-called dynamic zero control policy, which was to suppress the circulation of SARS-CoV-2 as soon as we identified surges of cases. So for the first 2 years of COVID-19 in Hong Kong, the cumulative incidence of COVID-19 in Hong Kong was below 1%, meaning that lower than 1% of people have been infected by COVID-19 during the first 2 years of the pandemic. It wasn't until Omicron emerged and spread to Hong Kong that the dynamic zero control measures that used to be able to suppress the virus were no longer effective, and then we had a huge Omicron wave. But even in the context when circulation is substantial, wastewater surveillance was still very useful for estimating the prevalence of the pathogen, of the disease in the community. So what I'm showing here in this slide are some of the excerpts from the news media on how wastewater surveillance had been used during the first 2 years. So basically, it was used to detect cases as soon as possible so that targeted contact tracing and isolation and then mass testing could be deployed. So what happened in Hong Kong was that as soon as a district had a positive signal in the wastewater surveillance system, then the corresponding area will be ring-fenced, and then those people who are living in that closed area will be subject to mass testing. And when Omicron started spreading in Hong Kong during the first half of 2022, we used the wastewater surveillance to estimate to track the prevalence of the disease, not in an absolute way, but in a relative way, meaning that the viral load data from wastewater surveillance, we found that it was a very reliable estimation of whether cases were going up or coming down, which was difficult because during Omicron, it was the first substantial wave of COVID that we had in Hong Kong. So testing capacity was overloaded, which means that we could not rely on the official COVID-19 clinical and virological surveillance to make an assessment on the changes in the number of cases over time because of, for example, differential health-seeking behavior over time, and also saturation of testing capacity over time. In contrast, wastewater surveillance was relatively stable, the viral load that we see, because the signal that we get are not as sensitive to health-seeking behavior and testing capacity constraints. So using the wastewater surveillance data as a proxy for viral activity in the population, in the context of modeling, we use that as a proxy for the shape of the force of infection over time. So we use that in order to update our model on a daily basis to provide nowcast for the Hong Kong government in order to respond to the Omicron wave. So my colleague, Professor Kathy Leung, in my group, has been working with me on this, and I understand that she also gave a talk to the same audience a few weeks ago in this series. So this is, I think, a paper in print in engineering showing that indeed, so this is a retrospective study looking back at how good water surveillance, the viral load in wastewater surveillance, how good a proxy it is to the actual viral transmission happening in the community. So the gray bars are the daily reported cases, and the red and greens are moving averages. So red are moving averages of the virus concentration, and green is the moving average of reported case number. So as you can see, there's substantial circulation, especially after the first wave. The fifth wave, which means in the later half of the year. The green and blue curves are coinciding quite nicely, but during the Omicron wave, there were substantial discrepancies over time because case counts were much more sensitive to testing capacity, as mentioned earlier. This was another study that we did, basically combining the wastewater surveillance data with the data that we get from serological surveillance. So in this study, we collected blood after the Omicron outbreak was almost over, and then based on the serological data, which reflects whether a person has been infected by COVID recently. So we combine that data with the wastewater surveillance data to assess what proportion of the population have been infected during the Omicron wave, and also the vaccine effectiveness against infection. So again, here, the way that we use the wastewater surveillance was to use the viral load up and down as a proxy for force of infection. And these are another 2 recent publications from our group in collaboration with our colleagues from civil engineering, who did the wastewater surveillance lab work for other pathogens, here mpox and influenza. So at the moment we are planning to sort of replicate what we did for COVID for influenza. That's all I would like to share with you today. Thank you for listening.
Thank you very much for a very broad talk and very interesting, really contribution. I can imagine there are many questions, and I would be happy to start with the first. Maybe, well, jumping to the first topic, in infodemics. Of course, the name suggests that it's information spreads similarly to epidemics, and there are a lot of parallels. And I wonder now, could you speak a little bit to the challenges of modeling or predicting infodemics versus well, the outbreak of a pathogen? Because I could imagine that infodemics maybe has a much better data situation if we talk about tweets going viral or other things that are really logged digitally. But then it also has its own challenges, surely. So from a modeling perspective, how do infodemics compare to pathogen spreading?
So in our group, we didn't actually do the research on modeling or predicting or not modeling infodemics or predicting infodemics, but instead sort of monitoring what is being spread in the ongoing infodemics in order to understand the situation better, which will help a lot when we make assumptions about when we make assumptions in the epidemic models that we do. For example, vaccine uptake is something that has of course a strong impact on the outcome of the model. At the beginning, when vaccines became available in the first quarter of 2021, people were expecting that, okay, now that we have safe and effective vaccines, and COVID should be over within 6 months or so, as long as coverage is strong. I think there were a lot of surprises among a lot of people on how low uptake were, even in high-income countries which were the first places to have access to the vaccines, including Hong Kong. For example, in Hong Kong, Omicron didn't hit until almost a year after COVID vaccines became available, more than a year actually. But when Omicron hit, there were still very low vaccine uptake among the high-risk groups, namely the elderly and those who had comorbidities. Monitoring infodemic, what is being talked about, why are people not taking vaccines, were very helpful for us to understand what assumptions is valid, is reasonable for incorporating into the model in order to generate the nowcast. So here we didn't do the modeling of infodemic, which I understand there's a huge amount of work in the literature, and like you said, I think data are relatively more accessible for sort of like landscaping what's going on. But as this article from the BMJ collection has mentioned, the platforms such as Facebook or Twitter, or Facebook in particular, even though some data were available for researchers to work on, during COVID, especially. I think that portal is closing recently. So again, there are barriers to that stream of work.
Okay, thank you very much. I would invite anyone to raise their hand if they have questions from the audience. Yeah, please don't be shy. There's a question in the chat, so I can just read it out from John. Could you please give some insight into the content of the interventions beyond the technical approaches to evidence generation in the area?
So what was the question?
It's in the chat. If you could give some insight into the content of the interventions beyond the technical approaches to the evidence generation in the area. John, may I put you on the spot? Maybe to clarify a little bit or give more details.
Sure. No, sorry. Probably I wasn't clear enough there. Let me turn on my camera. Thank you very much for the presentation. Really interesting. No, I was just interested in the, as I say, the content of these sorts of behavioral interventions. I mean, I understand the use of AI and the different technologies for gathering the evidence, but what are the interventions that you're actually doing? For example, I think that promote HPV that you used that seemed to be quite successful. So what was the intervention that was used to do that?
In the Japanese in the chatbot study, so what we did was that we recruit the control arm and the intervention arm, and in the control arm we give them the basically public health information on the safety and effectiveness and necessity of the vaccines. And in the intervention arms, in addition to that, we also give them access to a bot that we built, which can answer the same kind of questions, but in a more verbal way. So rather than asking the subjects to browse through the pamphlets, they can just ask questions directly and get a response. And from talking to the subjects, and also outside the context of these field studies, our understanding is that people these days are much less reluctant to look for information by browsing the internet or browsing any kind of information. I mean, they expect answers to be available directly to the questions. So, I mean, informations are abundant. I'm sure in the CDC, on the CDC website, NHS website, and also the Center for Health Protection in Hong Kong, they do have official web pages on vaccine safety and effectiveness, but very few people would be able to find or willing to find their answers from reading those pages, because sometimes they are very technical, too long, too verbose. So when we develop the chatbots, we try to make succinct, concise responses. And when we that's why we said effective interventions would include crafting effective framing, how to frame the vaccine messages. And another thing that we learned is that so here the bots are basically one size fits all. Whoever asked the question would get the same response. So what we find is that whether a vaccine message work will very much depend on the demographics and background of the subject, and also specifically why a subject is vaccine hesitant. It could be cultural, it could be due to religious reasons, it could be due to previous unpleasant behavior, it could be due to recipients, receiving misinformation, etc. So that's one thing that we learned from doing these studies. And like the article shown here, and BMJ has emphasized, it's very likely that we will need, a very diverse set of interventions specifically targeted at different subgroups in the population, because these subgroups have different reasons for being vaccine hesitant. Over.
So can I come back on that? It sounds very interesting, and I think the possibility for using AI and so on for understanding the people who are asking the questions is, something. It's not in my area. I don't understand how you would do it, but it's quite clear that it's something that offers a lot of potential. And it seems to me that the key here is that it's not just about giving facts, because a lot of low suboptimal vaccination acceptance and uptake is not to do with not knowing, it's to do with many other things. And you just mentioned cultural issues or having bad experiences with the health system and so on. So I think that's the key, which is not, so I think that the mistake would be just to focus on giving facts, but rather to make sure that the other elements that have been shown to be quite relevant here are also taken into account. Thanks very much.
Definitely. I mean, a moonshot, project would be if we can develop an AI assistant for doctors and nurses. So such an assistant, in real time, when our frontline healthcare workers, when they talk with the patients or subjects about their decisions on vaccination, the AI could in real time try to make an assessment on, okay, why is this patient or subject being vaccine hesitant, and may even suggest how to respond to the patient or subject in order to help them make better informed decisions. So not necessarily persuading them to get vaccinated, but what would be a more effective way of delivering the same kind of facts, accounting for the cultural background and accounting for the current state of vaccine sentiments. Over.
Thanks a lot. Again, please raise your hands if there are any questions. I would wonder about the wastewater surveillance. You showed some very interesting papers where you demonstrated the potential of wastewater data or surveillance data for modeling and for understanding the spread. Now I wonder about the traditional data streams. I mean, here, of course, they're collected in a very different way, and they have strengths and disadvantages. And what would be the best of both worlds? Looking some years ahead, how would you combine the two data streams? Or in what situations would you rely more on the one and less on the other? I realized you had there exactly that paper on seroprevalence, serological data, with combined with wastewater, and I wonder if, where you see the future of combining these two data streams.
So in what we do, whenever possible, we try to integrate all the data streams into the model as much as possible, so that we can reconcile their differences. We don't a priori, favor one over the other. So like you said, in this paper, we had two streams of data available to us, the serological data and the wastewater surveillance data. In another ongoing study of ours, we are basically looking at the same wave, the Omicron wave in Hong Kong, combining wastewater surveillance data with the prevalence survey, which I think is known as the REACT study in the UK. I think many of you should be familiar with the REACT study led by Stephen Riley and colleagues in the UK, which basically every week they sample the general populations and ask the subjects to do self-swabbing with rapid antigen test and report the positivity of those tests. And that would be an estimate of the prevalence of the disease in the population, in the general population at that particular time point. But that in itself might, well, first, it's very resource intensive, which means that the sample size might be small, so the uncertainty might be quite high. In this case, the wastewater surveillance data might be able to help, reduce those uncertainty, because as mentioned earlier, wastewater surveillance, the viral load could serve as a normalized proxy of disease prevalence, whereas the REACT type of study would give you an absolute measure. So the idea is similar. Serological data also gives you absolute estimates of the absolute number of infections in the population in a cumulative way, whereas the REACT type of study will give you a cross-sectional preference estimate. So in the future, I see that these would be used more and more common, especially for flu. The idea is kind of, again, similar to how Google Flu was being advocated as a useful tool. If wastewater surveillance could be done routinely, then because of the sensitivity of the system of the surveillance to the presence and the level of circulation of the pathogen in the community, it could substantially reduce the lead time of getting estimates on the basically nowcast. So Google Flu was advocated because it was argued that it took the CDC, at least a week in order to compile all the data collected from different sentinels and then to generate the estimates, whereas Google Flu could be automated based on real-time search volumes. So I foresee that wastewater surveillance could also serve such purpose if integrated properly. Over.
Yeah, indeed, I'm really looking forward to future surveillance data streams and combining them. And then, of course, the situation can be quite diverse in different locations. Are there any other questions from the audience? Not, I would thank Joseph very much for a great presentation, and Emily, you put your camera.
Thank you. Hey. Thank you for having me.
Sorry, I think Emily just raised her hand. You may get another question if you don't mind, Emily.
I just posted a question in the chat. Can you hear me well?
Yes.
Okay. Yeah. So thank you for an excellent talk. You mentioned the Foresight group. On what projects are you collaborating with them?
The Foresight group. Sorry, which group are you referring to? Sorry, Emily, which group are you referring to?
Emily, can you hear us again?
Yeah, okay, sorry, I will repeat my question. So thank you for an excellent talk. I posted a question in the chat. You mentioned the Foresight group. On what projects are you collaborating with them?
I'm not sure which group you are referring to. Is it about the wastewater surveillance or vaccine hesitancy?
Yes, both. Are you collaborating with the Foresight group on these projects?
You mean the group led by Heidi Larsen?
Yes. Yeah.
Oh, the Vaccine Confidence Project.
Okay.
So
thank you for the clarification.
Yeah. So Heidi has been running the Vaccine Confidence Project at Linden School since 2010. So what she does is she's one of the first people to work on vaccine hesitancy, and for the first decade of her project, she worked closely with both local jurisdictions and also the WHO on advocating, that it's not just the pathogen itself, but it is also the public perception and attitudes towards the epidemic itself, and also the interventions that would affect the outcome of the pandemic. So she has been working on this for more than 15 years now, And we started working with a group about 5 years ago when we started the AI lab that I'm running, basically trying to use AI to deploy AI techniques and analytics to help her scale what she has been doing on this topic for the first decade of CCP, because previously they were curating information and collating information quite manually. So basically, her team, each member of her team will look at, literally what's being talked about in discussion forum, in newspapers, in Twitter, in Facebook. But these days we are now able to, we have now AI tools that could help her group to do these things much more autonomously and much faster. So yeah, that's what we are doing with Heidi's group.
Thanks.
You're welcome.
Okay, then thank you very much, Joseph. And yeah, we welcome you back as a listener, of course. And yeah, thanks a lot for the talk. And have a great evening.
Thank you. Thank you all. Bye-bye.
Goodbye.